A very good afternoon to one and all. Welcome back to the Master webinar series from Faculty of Dentistry. So today our topic is on the clinical tips for successful crown and bridge preparation. So I would like to welcome our today's speaker, Assistant Professor Dr. Santosh Kotian. So I would like to introduce him. So Assistant Professor Dr. Santosh Kotian is currently the Head of Program, Doctor of Restorative Dentistry at Masa University. In his 14 years of teaching and clinical experience, he has gained extensive and valuable experiences in academic and clinical areas while working in various universities in India, Libya, and Malaysia. He has successfully guided and supervised undergraduate and postgraduate students in clinical and preclinical exercises. He has conducted jobs related to clinical and laboratory procedures in complete dentures and clinical procedures in crown and bridge. If you have any questions, you please do a comment in the comment section. We will answer you at the end of the presentation. So without any delay, I would like to welcome Dr. Santosh Kotian and enlighten us on the crown and bridge preparations. Thank you so much. Over to you, Dr. Santosh Kotian.
Thank you, Dr. Raghavendra, for the nice presentation. Thank you so much. Hello, good afternoon, everyone. I hope, and good morning to some of my students who are watching me from Libya. I'm Associate Professor Dr. Santosh Kotian, and today I'm going to present my seminar, my webinar on clinical tips for successful crown and bridge preparation. We all know crown and bridge is the bread and butter of dentistry, right? Probably endo and crown and bridge are the most common treatment procedures done in the dental clinics. So, okay, let's hop on. Let's go through. A little bit of me just for the intro. Well, the people who have shaped me and carved me for what I am today, my parents, ever thankful to them and ever grateful to them, and my extended family, some of my really close friends and family members. I'm very thankful to all the love and all the support they have always shown me. Then coming to my professional career, yes, I'm currently working in Masa University since 5 years now, and very happy to be here. I've had a very enriching experience here, particularly under the guidance of our Dean, Prof. Dr. Rosna, whom you're seeing in the picture now. Got many opportunities here to have conducted many workshops, done presentations in conferences, been to some teaching and learning activities also, some reflective learning sessions and etc. So currently I am the head for the postgraduate program, which is the doctor in restorative dentistry. So basically it's a doctorate program. So I am currently the head of the program. Have been a very fun experience also over here. It's not only academics. Made some very good friends among my colleagues over here. I have some old friends also working with me over here. And students are always darlings. They always have a good time with us. They always make sure the studies are also fun. And we have our parties, etc., along with our academics. Plus, Malaysia has been a good place. I think it's a good, very strategic location. After coming here, I've actually traveled a lot than I did in my previous years of my life. So I've seen a lot of places in and around Malaysia. That's about me. And yeah, this is Masa University, what you're seeing on your screen now. Like I said, I have been working here since 5 years now. and it has been a very enriching and fulfilling experience. Masa University actually has a lot of faculties under them, ranging from medical, dental, engineering, business, pharmacy, physiotherapy, nursing, etc., and many more to come, I hope. Just a little bit introduction about Masa, in case you already don't know, in case you're someone outsider from Masa. Well, if you go to the webpage, masa.edu.my, you can just scroll up to the faculty section here. You can see dentistry. And then if you go there, you are welcomed by our dean on our dental web page. And if you just scroll down there, you can see about the 4 main programs that we are running. So one is the DDS program, the undergraduate program, and then we have 2 postgraduate programs, which is the Master of Orofacial Sciences and Doctor in Restorative Dentistry. So currently we are running this program in 2 specialties, which is Restorative Dentistry and Periodontology. Restorative Dentistry basically includes a majority of prosthodontics, and some components of endodontics and a minor component of perio, including implantology. Okay, so your master program is basically a bridging, 1-year bridging program between DDS and doctorate. Okay, and to join this program, you actually don't need any clinical experience, which means that the moment you graduate from DDS, you can actually join our master program. Okay, but only thing is, for a doctorate program, you need 2 years of clinical experience. So while waiting for your government postings, in that period of time, you can actually join our master program, and then you do your clinical service for 2 years in government or outside, and then after 2 years, you can join back and continue the doctorate program. Apart from that, we have a dental technology diploma program also. So that means we have our own dental lab and a lot of dental technicians and students. So most of our laboratory work for the treatment purposes happens in our institute, and we are constantly upgrading also. Very soon we'll be digitalizing our labs and getting into starting with the CAD/CAM fabrication of prosthesis. Just in case you didn't know where we are located, this is Bandar Saujana Putra. Okay, towards the, maybe you take the highway towards Putrajaya, and very easy, you can just Waze nowadays, it's so easy, Masa University, Bandar Saujana Putra, and it will bring you here. Our students excel in academics every year, but not just academics. There's a lot of co-curricular activities happening. As you can see here, this is the gallery from the Masa University webpage itself. You see that there are a lot of activities happening. We have our sports activities, annual dinners, etc., which is a lot of fun. Well, why study in Masa, you may ask? Why not? We have a lot of international and local staff, highly professional, and with a lot of high degrees and a lot of years and years of clinical and research experience behind them. So our core team is very strong with a lot of experience, plus the infrastructure. We have a lot of instruments and equipments that a dental setup needs. Everything is available. The staff student ratio is 1:6, which is a very good one, and as MQ recommended. Plus, other than that, our campus has a lot of sports facilities, gyms, swimming pool, etc. You should visit the campus. If you have never been here, you should visit the campus to have a look. This is our undergraduate clinics and simulation labs. This is our postgraduate pictures, some of from our postgraduate program, where students are taught both the laboratory as well as the clinical treatment procedures. As you can see, our endo, the postgraduate student doing the endo treatment using the operating endo microscope. In case you want to know more about Masa University, you can just find us on Facebook, Instagram, and YouTube. We also have our clinics running, and given the pandemic situation, all SOPs are followed. Temperature checking, even any patient walks in or anyone comes into our campus, the temperature checking is done, temperature scanning is done, and the patients mandatory, they have to fill up a questionnaire and give a history of their recent traveling. So yeah, so the patient treatment happens here not just by the students but also by the lecturers. So this is so that's about it. So I think now it's time we can start my webinar after this brief introduction. Um, this is one of my favorite quotes that I've heard. It is actually from one of my teachers, Dr. Anand Krishna. He's a very popular consultant prosthodontist in India. And in one of the courses that I attended with him, this is what he said: we need to unlearn to learn. And it has been stuck in my brain ever since. And I'm very thankful for him to have said that to me, because I think it's very, very important, because learning is a continuous experience. I think learning never ends. And the moment we stop learning, we stop growing. And sometimes what happens is that our mind is filled with so much information, it creates a block and we are not able to learn something new. So I think that is why it's very important that we should unlearn to learn. Okay, so I usually follow that. So whenever I'm attending a course or I myself go for a workshop, I always try to just subdue whatever I know and try to learn the new information. So likewise, what you might see in the webinar today might be something that you already know, but this is something that can refresh your knowledge or enrich your knowledge, or just add on to your existing knowledge. Well, I think this is a dilemma. This perfectly represents the dilemma that probably students or fresh graduates experience, because you have just 3 years of clinics done, and sometimes it's not enough, okay? Because dentistry is such a wide branch involving so many subspecialties that sometimes the time may not be enough to do that enough number of cases that you might give you the good experience. Because we all know the perfection, you can go towards perfection only by doing more and more cases. That's the only way up. Can understand the dilemma or the nervousness of a fresh graduate. I'm trying to relate to a fresh graduate's psychology now, because how you might feel when you enter into your clinics outside the comforts of the university, without your favorite lecturer looking over you. So I think that is an attempt in my webinar to go through these points, these aspects of crown and bridge preparation, which we might know, but we might ignore, we might neglect, we might overlook, and some essential tips that will make the whole process a bit easier. So, what basically goes wrong in a crown and bridge preparation? The usual complaint that we see is in the last appointment, right? Sometimes until the last appointment, we don't realize what has happened. So usually what's happening, your crowns or bridges, they are not fitting, right? They either have a poor fit, or you have a lot of high points, or the shade mismatch. The shade is not matching. But what is the reason for it? I think we need to track back. Okay, we need to go back and see where the problem is coming from. So probably the errors have happened during the clinical trying stage, or any laboratory errors. That is, any errors during the laboratory processing done by the laboratory technician. Or it could be even going back further to the previous appointment, maybe errors during your tooth preparation or impression making procedures. Or if you go back further, the root cause of most of the failure cases is poor case selection or a poor treatment planning. Okay, so usually this is the root cause of all the problems. So I'll try to focus on this. So like I said, my webinar, I will not tell you on how to prepare teeth. Okay, I think most of you have already studied this, and you know more about it, and there are a lot of videos available online will tell you how to prepare. But my focus will be on how to better your tooth preparation or other procedures, and how to look into those gray areas and how to improvise. First and foremost, like I said, is very important is case selection. Okay, there is this series of article in BDJ, British Dental Journal, which you can if you can Google and find out. It gives you a series of problems that a patient can come, or you in your treatment procedure can happen. So let's just breeze through some of the important areas that can cause a problem in case selection or treatment planning. Chief complaint. This has been repeated to us many times. Chief complaint. Listen to the chief complaint. Very, very important. Okay, understand the patient's expectations, because sometimes the patients may have some over expectations or some unimaginable expectations. So you need to understand and gauge the patient. Okay, whether the patient's expectations are realistic or not. Also, the first appointment is the time when you can analyze your patient. Okay, the psychological assessment of the patient is very important. Whether how cooperative your patient is, how understanding your patient is very important. So likewise, you need to change how you communicate with the patient. Clarity, be very clear. This is very important. Always take that time out in your first appointment to explain everything to your patient. Okay, never rush through it. Explain everything to your patient. What is the patient's existing condition, and what sorts of treatments and the treatment charges that might incur. Take into consideration the age of the patient. Very important. Your treatment planning can change depending on the age of the patient. History, again, very important. Past dental history gives you an idea about what other treatment procedures the patient has undergone, and or any kind of complications that the patient has had during the previous treatments. Medical history and medications history will give you an idea about the patient's existing health condition. So there might be some certain health conditions that may not permit you to do certain procedures. Coming to crown and bridge, there are no absolute contraindications for the crown and bridge procedure unless the patient gives you a history of allergy to any particular materials, which again you get to know from the past dental history. Also, certain medications can cause xerostomia, that is dryness of the mouth. Now, this is very important that you have to observe this one, because usually xerostomia is somehow related to poor oral hygiene, because of the saliva flow being less. There is a high caries activity, and especially if you give crowns and bridges, there could be there are high chances of having marginal caries. Oral hygiene status of the patient, again, very, very important. In fact, if you see some of the literature, they say that oral hygiene, a patient with a poor oral hygiene status is an absolute contraindication for a fixed prosthesis. Okay, because a fixed prosthesis is something that requires high oral hygiene maintenance. So what do you do if your patient has a poor oral hygiene? You don't outright send him back. So you counsel the patient on how to follow the oral hygiene procedures, and give 2 weeks to the patient don't straight away start with the treatment procedure. Give 2 weeks to the patient to follow the oral hygiene maintenance, do the scaling. When the patient comes back to you after 2 weeks, observe the patient's oral hygiene, and if there is an improvement, then you go ahead. Extraoral and intraoral examination, a proper examination of the TMJ, palpation of the facial muscles, mouth openings. They'll give you an idea about the patient's TMJ status. If the patient has got any problems, maybe from any intraoral conditions like bruxism or any other associated issues. An intraoral examination, please do look, if your treatment is particularly for crown and bridge, please do look for the condition of the existing teeth. That is, if you're doing a crown, the tooth that you're going to prepare, or if you're doing a bridge, the abutment teeth. Look for any old restorations, any failed restorations. Look for the amount of remaining tooth structure Okay, any discolorations, any caries, because sometimes caries may not be visible, proximal caries may not be visible. Look for the length of the edentulous span, very important, because if you have a distal extension, obviously you cannot give a fixed partial denture. But at the same time, if there's a lot of teeth missing in a tooth-bounded edentulous span, also it could be a contraindication for a fixed partial denture. So depending on case to case. And look at the ridge. If it's a bridge case, look at the ridge. Form of the ridge. If the ridge is too resorbed and knife edged, you might have to do some ridge augmentation procedures. And of course, the gingiva biotype, you see whether the gingiva is thin or thick, which will also be helpful for you to decide your gingival retraction procedures. Occlusal analysis, very, very important. Okay, the lateral occlusion of the patient, whether it is a group function or a canine guided, will have a very strong effect on your treatment plan. Anterior guidance and any interferences. So these three aspects especially you have to note down, and it's very important, especially if you're replacing anterior teeth. Then the anterior guidance and lateral occlusion also becomes very important to note down. Any radiographs required, either IOPA or usually a IOPA will suffice. But if you have further doubts, something further confirmation, you can go for CBCT if required. So what will you look for in radiographs? The crown root ratio, okay, the ratio of the crown to the root, the condition of the surrounding bone, the bone support that is available for the abutment teeth, the root morphology of the abutment teeth, any caries that is not visible clinically, the periapical condition of the teeth, and condition of the previous treatments done. So especially endo treatments, if the abutment tooth is endo treated, you might have to analyze it through the radiographs. And again, coming to one of the most important things that is important is diagnostic impressions, cast, mounting, and wax up. Now, one thing I would like to add on here is that when we say impressions, we always associate it with prosthodontics, right? I want to highlight here that please do not consider impressions as a prosthodontic procedure. That is, okay, I have to make an impression only when the patient needs the replacement of teeth. No, that's not the thing. Always make a diagnostic impression and diagnostic cast. For most of your cases, it's always helpful. Once you have a diagnostic cast, you have the patient's original record of their teeth, of their dentition with you, which is very, very useful in case of any future problems, any differences in understanding between the patient and the dentist. It serves as a good record of how the patient's teeth was. Plus, in patient education, very, very useful, and as well as in treatment planning. So I will now go through more into highlight more on the diagnostic impression, cast, mounting, and wax up aspect. This is just a reference for you. What I said just now in the previous slide, this is actually, you can find it in a table in the latest edition of Schillenberg. You can just go look for it. It is in chapter 7. This is just a part of that table. It's not the entire table. So it's just a reference for you because it's a good summary of what are the treatment options based on the patient's intraoral condition. Diagnostic impression. So I'll start with the primary impression, like the most important impression. Sometimes we tend to neglect. We think that primary impression probably not so important, and we do it in a hurry. But no, primary impression is very, very important. But the problem here is we are doing it with the stock tray, that is a prefab ready-made. It's a ready-made tray. So as you know, ready-made trays may not fit every mouth properly. So it's very important that you bead the impression tray. Once you bead the impression, remember, wax is also an impression material. It is moldable. Especially in cases where the patient has a lot of proclination or a long edentulous span somewhere with other remaining natural teeth, it is very difficult to seat your impression trays. You might have observed that already. So when you beat the tray with the modeling wax, it allows you to adapt the tray or customize the stock tray to the patient's mouth. So just use a bowl of warm water, soften the wax, cut it, and beat it all around the tray. It doesn't really take a lot of time. So especially in cases where you have a lot of proclination or a lot of malalignment of the teeth, you can in fact once you beat the tray, you can in fact dip it in warm water and just mold the wax in the patient's mouth before you actually do the impression. So you can actually exactly customize the tray in the patient's mouth and then do the impressions. So usually when we ask students to do the beading, they are a bit lazy, and we see that they take like 10 to 15 minutes to do the beading. And if my students are watching, we already know that I was telling it just takes 2 minutes. It really takes only 2 minutes, doesn't take much of a time. I'll actually show you the video for that. So this is what I was talking about. What happens when you have a cast, like when you have patient's dentition like this, some teeth present, but then you have long edentulous spans, sometimes in the posterior, sometimes in the anterior. So the fitting of the tray becomes a challenge, okay? And that is where the beading helps. So I'll quickly show you this video. It is in 2x speed, just to save time on watching. But if you see that the entire video is about, I think, 1 minute 20 seconds something. So which means that in normal speed, it just takes about 2.5 minutes. So cut a strip of wax, dip it in warm water, and just beat it all around the tray. One more thing, whenever you're softening wax, always use warm water and not flame. Do not use flame. At least with warm water, you get a uniform softening of the wax. Heating of the wax with the flame, you will not get a uniform softening. So you see how here it is done. So especially in the lingual areas, mandibular lingual areas, sometimes you may not be able to adapt properly. So this kind of a beading, when you do, and you can, like I said, you can just dip the tray with the wax in warm water and adapt the wax in the patient's mouth. So this helps you to get a very good primary impression. You can in fact compare your impressions done without the beading and with beading, your alternate impressions. If you compare, you'll actually see the difference, the quality of the impression, and even in a primary impression, you can get a good sulcus recording and even the free knife. So if you see these impressions over here, they have been taken in a single take, and there's a labial frenum, there's the lingual frenum you can see here, you can see the sulcus recordings, and this is done in one take and just in the little bit of working time that Alginate provides you. So this beading basically helps you to get a better molding of the alginate impression material. So this is another picture to show you. One more thing, aspect to evaluate your impression, apart from the sulcus and freni recordings, is the depth. Okay, always make sure there's enough depth in your impression. Okay, if wherever the teeth are present, wherever the natural teeth are present, the natural teeth occlusal area should be almost touching towards the surface of the tray underneath. Another advantage here is even if you might question here that the wax is exposed. So even if the wax is exposed inside over here, it's still okay, because wax is also an impression material, and because of the oral temperature, the wax gets molded over there, and you still get an proper recording of the tissues. It's always better than the tray being exposed. Because in this situation over here, if there was no beading, what would have happened is you would have seen the border of the tray, which is definitely not acceptable. And you'll be pouring, and if you still pour a cast, you will see that tray indentation in the cast, which is definitely not acceptable. So this is another advantage of using the beading. Once the casts are poured, mounted, and this is one what you see people mounting is on the hinge articulator. In MASA, in our department, we have been strictly against using hinge articulators. we don't use hinge articulators anymore unless it is for simulation sessions only by the dental technicians that do. The main reason why we do not advise hinge articulators is because hinge articulator has practically no science there. The only science over there is the hinge that opens and closes, just like how a door opens and closes. Okay, what I have pointed out here is the location of the actual mandibular hinge axis in a human being, and the hinge axis in this articulator. So this picture is actually inspired from the picture given in Schillenberg. The same picture is given in a Schillenberg in a graphic manner, and this is the difference between the location of the mandibular hinge axis and the articulator hinge axis. So you see that's a lot of discrepancy, which results in a discrepancy in your crown also, and your crowns come up with high points. As opposed to that, if you see the adjustable articulators, you see the difference over here. Very minor discrepancy between the location of the mandibular hinge axis and the articulator's hinge axis. As a result, the discrepancies that come out in the crown are also very minor, which are easily adjustable. Plus, this articulator that we are using at MASA is also an Archon articulator with the condyle in the lower member. So also Archon articulators have this added advantage over non-Archon articulators, that the relationship between the condylar inclination and the maxillary occlusal plane remains constant when you open and close the articulator. In normally non-Archon articulators, because the arrangement is reverse, the axis and the angulation changes. The relationship between the condylar inclination and the maxillary occlusal plane changes when you open and close. So this can also cause errors, especially in long span bridges. So this is another advantage of using the Archon articulators. So this is just a representation for you to understand the difference in the just the size of the articulators itself gives you an idea about how different the angulations, opening and closing axis can be in articulators. So highly recommended to use a semi-adjustable articulator, or if not, even a mean value articulator, because you know that the mean value articulator has been made with all the average values and settings. So you can still use a mean value articulator, but definitely I would not advise to use a hinge articulator. Coming to wax ups. So one example over here, you can see how wax ups can help. This is a patient back in our MASA clinic where he had an open bite over here, and then patient required anterior crowns, and we did a wax up to show the patient how it will look like once the crowns are made. So it gives you a good visualization of the final treatment. Also lets you know whether actually the treatment can be done or not, whether there is enough space between the upper and lower anteriors or not, or if it requires any kind of anomaloplasty for the lower anteriors or not. And also good in patient education. The patient also can visualize how the permanent crowns will look like. Plus, of course, when you make a diagnostic wax up, it helps you to make the temporary crowns. Apart from the regular diagnostic wax up that you do, nowadays, of course, you have a lot of smile designing softwares. Planmeca is one, and then there is Exocad, which is quite popular. And if you go to their website, and you can see, of course, they are paid ones, but I'm sure there are a lot of normal, simple smile designing softwares available online, which are not paid. And you can always try your hands on it and try to do the simple smile designing for your patients. Of course, Exocad and Planmeca are much higher versions where they can actually give you complete visualization of the final outcomes. They can also helpful in doing the digital wax ups, plus from which you can also print or mill the temporary crowns. The Exocad software, we have an MOU for a dental technology program with the Apex Lab, which is in PJ, and they also offer the Exocad training programs. This is a visualization of how the wax ups in the softwares look like, and the final visualization can be done using the smile designing softwares. The next important thing that we usually forget during the first appointment or before tooth preparation is shade selection. This happens so many times that we are training the students and the students say that they forgot to do the shade selection. So please always do the shade selection before you actually do the tooth preparation. It's very important. A lot of materials are available today. Apart from the conventional 3D master guide and the classical master guide, we have the spectrophotometers, which will immediately tell you the shade, plus now the intraoral scanners. The intraoral scanners also come with shade selection settings in the scanner, so it's also possible to do an accurate shade selection. So let's move on to the tooth preparation now. So once you have done your initial history taking and diagnosis and treatment planning, and once you have finalized that you're going to do a crown and bridge, we have to go back to our basics. Basics given by Schillenberg, which we have always studied in our program, the 5 principles of tooth preparation. Of course, there are some articles which have elaborated on them. This is one article that highlights the Schillenberg's key principles of tooth preparation. These familiar pictures for different kinds of preparation, how important is your tooth preparation design to contribute towards a proper successful restoration. So each part of the preparation, how it contributes to the principles of tooth preparation. I will not elaborate on this because this is something that we have already studied. So this is one article given also in BDJ. It is a series of articles actually on crowns and extracorneal restorations, and in the entire procedure, most aspects of crown and bridge restoration treatment procedure it covers, and you can actually go through it. You can collect this series and you can actually go through it, and gives you good information about crown and bridge treatment procedure. One more article here I would recommend, Tooth Preparations for Complete Crowns, gives you, summarizes the entire tooth preparation procedure and case selection in a very nice, simple and simple to understand way. The burrs, again, this list is from Schillenberg. There's a nice, beautiful table, which is a list of all the burrs that is required to do a proper crown preparation. You can always refer this list to select, choose your burrs. But of course, nowadays, kits are available. All different companies have crown and bridge preparation burrs kit ready-made to you. And once, if you're in the beginning stages of your practice, like for every other material, you will need a bit of trial and error to see what works good for you. Okay, so there is never a single recommendation of any material or any equipment. It's always about what works for you. So it's good to initially try out a few different things and then see what works for you, and then stick to one or two systems. So we use the Shofu crown and bridge preparation kit, and it has the flattened taper diamonds, rounded taper diamonds of coarse and fine, and there is short and super short burrs, because sometimes when especially you're doing the posterior teeth, especially the second quadrant, the axis is usually an issue. So you can use the short or the super short burrs to do the preparation. Likewise, there are the flame-shaped burrs, there is the veneer burr, there is the proximal cutting burr. The guide is attached, and you can always refer to that to do the selection of your burrs. Always make a proper selection of the burr. Use the correct burr for kind of preparation that you're doing. If you're doing a chamfer, go for a round and taper burr. If you're doing a shoulder, go for a flattened taper burr, and if you're doing a rounded shoulder or a heavy chamfer, you can go for a tapered fissure burr. A brief summary of the principles of tooth preparation I will just do. So the main factors that affect the retention and resistance is, of course, the magnitude of the dislodging forces, that is the kind of food that the patient eats. So it is very important you advise the patient not to eat a lot of sticky foods or crush heavy or hard food, especially if they have long span bridges. Yeah. Plus, the total success of a restoration is not just relying on cement only. If you're relying on cement only for your crown to stay there, then that is not going to work all the time. A few times it might work because of luck or something else, but it will not work every time. So it is very important that you concentrate on the design of your preparation. Okay, the recommended taper, length, surface area, very, very important. Roundation of all the sharp line angles, very important. And if you're doing a bridge, then parallelism and path of insertion, you need to look into that. Make sure your abutment teeth are parallel to each other and have a single path of insertion. One tip that I recommend here is that if you're doing a bridge, always start the preparation from the posterior teeth. Okay, do the preparation of the posterior tooth first and then do the anterior tooth, because it's easier to orient the anterior tooth parallelism to the posterior tooth rather than the other way around. Okay, so if you prepare your posterior tooth first and then when you prepare the tooth anterior to it, you can easily orient the parallelism to that tooth. Taper, like how we have studied in books, is 6 degree, we say, but most studies show that it is not just 6 degree, because 6 degree is something that is, it's very, very, very tiny. And unless you are a really, really skilled, efficient dentist, sometimes it might be hard to achieve. The average tapers that is usually seen is about 10 degrees anterior teeth, 14 in premolar, and 22 in molar. So basically it is because of the size of the tooth, the size of the surfaces of the teeth. Okay, and that's how that's what contributes to the total taper. Fitting surface of the restoration, that is the material of the crown. What material of the crown are you going? Is it a metal crown? Is it a PFM crown? Is it an Emax? Is it a Zirconia? So this will also decide how the crown will fit in or adhere to the tooth. We will elaborate on that later on when we go to the cementation parts. Material being cemented, whether it's a crown, whether both the crown material as well as the cement material, and the type and film thickness of the cement. Basic. What we already discussed is the path of insertion. You need to have a proper taper, length, and surface area so that the design itself gives the retention and resistance for your preparation. The anterior teeth, when you're preparing, especially the two plane, becomes very important in the anterior teeth. If you do not follow the two plane, then either you're going very close to the pulp, or the final outcome of your crown is going to be not very aesthetic. Okay, because then the laboratory technician has to make up for your over reduction. The ceramic thickness will increase, and then it will not be very aesthetic. Even when you trim the buccal and palatal surfaces, make sure you follow the two plane in a mild way, not as accentuated as the anterior, but still you need to follow the two plane based on the position of the height of contour area. Functional bevel, cusp bevel, again very important aspect, and then stick to the preparation guidelines, that is amount of tooth reduction to be done based on what crown you're giving. So let's breeze through the occlusion, through the tooth preparation steps now. So this is the steps that we usually follow, right? The occlusal depth guides, occlusal reduction, axial reduction, functional cusp bevel, finishing the preparation, and evaluating. So I will just give you some tips on how to go through this, how to make it an easier procedure. First of all, make sure that you are ready for the tooth preparation procedure. So what do I mean by that? Depending on what quadrant you're doing, especially if you use the upper teeth, make sure that you have the solution to the mirror solution, the potassium solution, which makes the mirror not wetted by the saliva. Okay, it doesn't coat the saliva with the air or water, so that you have a clear vision. Okay, otherwise it's a tough time. You have to constantly keep cleaning your mirror. Then comes the choice of the burrs. Make sure your burr is not an old worn-off one, and choose the correct burr. When you're doing occlusal reduction, do not use any sharp end burrs. That is, don't use your flat end burr, because your flat end burr will cause a lot of sharp edges in the grooves and fissures, which you might have to take another burr to remove those grooves and fissures. So when you do this extra work, you end up doing over trimming. So try not to do that. And angulation of the burr, very important. Follow the angulation of the cusp. This is the basic rule. Okay, follow the angulation of the cusp. Do not change your burr angulation from that of the cusp. Okay, this is very important. And make the depth orientation grooves. Do not overlook this depth. Or even now, after 14 years of experience, also I still do depth orientation grooves. Okay, so it really helps you to do a uniform reduction, and you don't over prepare. For the anterior teeth, again, its incisor reduction is usually about 2 mm. For posterior teeth, the amount of reduction depends on what type of crown you're doing. But for anterior teeth, it is always 1.5 to 2 mm. Angulation of the burr. The angulation of the burr should be more. It's called lingual-gingival. Okay, lingual-gingival. That is, your burr should be slightly tilted towards the lingual gingiva. Okay, so this helps the ceramic contouring in this area, okay, because of the bevel that is formed. Check for clearance. Once you are done, check for clearance, very important. Okay, you can check for this you can do by using a modeling wax, or you can also use a Byte Registration material to check for the adequate clearance. You can use a gauge to measure the thickness of the wax, or to measure the thickness of the Byte Registration material. One more thing, very important: never use your probes to measure anything. Okay, don't use the probe. This is again a very common mistake done by everyone. Using probes to analyze your tooth preparation, using probes to analyze the occlusal clearance. Never do that. Probes are not meant for that. Okay, use the burr itself to analyze your tooth preparation, because your tooth preparation is guided by the design of the burr. So use the burr itself to analyze your tooth preparation, and use either wax or Byte Registration material to check for the clearance. Next, going to the mesial and distal reduction, using of a burr, using of the needle burr to break the contacts, very important. Start from the top. Usually students say, we don't know how to start. Okay, that is the problem. So start from somewhere at the top, that is above the contact point, and slowly do the buccolingual movement and slide downward in a downward direction, and then break the contact. Always keep your burr a little away from the proximal surface. Don't keep it exactly at the proximal surface like shown in this picture. Now, this picture I have put in here to show that this is not how it is to be done. Okay, do not put your burr here. You need to put your burr over here. Okay, so that you are still able to maintain that proximal enamel while you cut through, and then you can easily chip off that proximal enamel. In case of upper posterior teeth, angulation becomes a big problem, especially when you are preparing the distal surface. This is another problem we normally face. This takes some practice, of course. Always use a clear vision through your mouth mirror, and secondly, place the burr in the angulation. Always tilt the burr slightly towards the mesial direction. Okay, because by default, without our knowledge, whenever we place the burr in distal as well as the palatal surface, somehow we tilt the tip of the burr towards the tooth, and we end up doing undercuts, okay, without our realization, because we think we are doing it properly. So it's very important that you remind yourself to just move your hand downwards and tilt the burr and the handpiece towards the opposite surface. That is, if you're doing palatal, slightly tilt it towards the buccal. If you're doing distal, slightly tilt it towards the mesial. So, but yes, of course, it needs a little bit of experience so that you don't end up doing a over tapering. Coming to buccal and lingual reduction, again, follow the planes. Most of the buccal and buccal surfaces have a very high contour, so do not make it flat totally. First, for the cervical 1/3 area, or cervical 1/3 or cervical half area, you do the keep the burr parallel to the long axis of the teeth, and then for the upper part, keep the burr parallel to the surface. So this is how it should be, and this is something that you should not do. Okay, this is something that you should not do over here. I hope the cursor is seen. I'll just put on the laser pointer. Okay. This is the this is something that I don't recommend. Okay, using the tip of the burr on the middle of the surface. What will happen is you will end up with another finish line over here, because that is the function of the tip of the burr. Okay, you'll end up with another finish line over here, and then you will use some more reduction to remove that line created over there, and then you'll end up with over reduction. Okay, so ideally follow the two plane. The cervical half, once you remove the occlusal reduction, then you can, once you've done the occlusal reduction, the crown height is reduced, then it's easy to do. So always do the occlusal reduction first. And once you do that, you can just divide the axial surface into two surfaces, not three parts. You can just divide into two parts, cervical half and occlusal half. Cervical half should be parallel to the long axis of the teeth, and the occlusal half parallel to the surface of the tooth. When it comes to an anterior tooth, once again, like you can see here, for the cervical half, please keep the burr parallel to the long axis of the teeth, and for the incisal half, keep the burr parallel to the surface. Again, do not bring the tip over here, okay? Because the design of the burr, the entire design of the burr from the tip towards the body all along is designed on how your tooth preparation should be. So which means that this tip area of the burr is designed for the cervical area of the teeth, and this body area of the burr is designed for the incisal area of the teeth. So do not change that. Okay, once you do change that, then your design of the final design of your tooth prep also changes. Okay, so always maintain this position. If you want to prepare the incisal surface, use this part of the burr and not the tip of the burr. Okay. Lingual reduction, palatal reduction, like I said, accessible areas with the proper visual access is not a problem. But if you're doing the upper teeth, first quadrant or second quadrant, then angulate your handpiece slightly towards the buccal so that you don't make an undercut over there. I highly recommend using flame burrs or the football shape burr rather to prepare the lingual surface of anterior teeth. Wheel burr is something that I've never been able to successfully use to do that. So we always recommend using the football shaped burr for the reduction of the lingual surface of anterior teeth. And you see that why? Because the entire surface of the burr easily adapts to the lingual concavity of the upper anterior teeth. Once your preparation is complete, analyze the preparation. Look from the top with one eye closed, and you should be able to see the entire finish line without moving your head. If any particular area you're not able to see the finish line in that area, that means that area needs some more reduction. So just mark that area and then do the reduction only in that area. Again, it's usually very tempting to just go around the whole tooth once again, but don't do that. Okay. If you see that the rest of the tooth is fine, just one area is a problem, just trim in that area only. And then you can use the finishing burrs to finish the preparation. There is an enamel adjustment kit. Normally, we are using this for enameloplasty or something like that. But you can use it for a final smoothing of your preparation. But at the same time, don't attempt to completely smoothen your impression. A little bit of roughness of your preparation is very important for micromechanical retention of the restoration. So you analyze your prep. When you see from a single view at a distance and with one eye closed, you should be able to see the entire finish line and also view your axial surface if there's a proper taper everywhere. This is a checklist. Once you've done your preparation, this is a checklist. Make sure there is no damage to the adjacent teeth, no over reduction, so no pulp exposure, no undercuts. Again, how do you analyze? Use the burr to analyze. Okay, once you're always stop and do. Never go on preparing your teeth. Okay, always stop. Use the burr, place the burr there without rotation, of course. Place the burr and see the gap between the burr and the teeth. If you see a gap between the tip of the burr and the tooth surface, that means you have created an undercut. Okay, and if you see a gap between the upper part of the burr, the body of the burr, and the tooth surface, that means you have over prepared. Okay, but if the tooth surface, the prepared tooth surface, nicely adapts to the burr from the tip to the body, that means your preparation is good. Okay, after that you need not prepare once again. Okay, so and then move the burr slowly all around the tooth. Maintain contact of the tip of the burr on the finish line and the body of the burr on the tooth surface. So slowly move all around the tooth. So which means that without change in angulation, keep your burr parallel to the long axis, all around, because when you change the surface, sometimes your hand tends to move and the angulation changes. So you need to concentrate on that. So constantly you should have a smooth movement. The tip should smoothly move over the finish line and the body of the burr should smoothly move over the axial surface. If you get any jerks here and there, mark that area and just trim in that area only. So similarly, that's how you check for undercuts and wall inclines. Occlusal reduction, I already told you how to check. You can either use a byte registration material or a wax. And then margin location, depending on whether you have decided to do supragingival or subgingival. So if it is subgingival or equigingival, you might have to use a gingival retraction. So make sure that you have not damaged the tissues and check everything, finish line continuity and interproximal clearance. This is a summary of tooth reduction for different types of crown materials. If it's a metal, usually the occlusal reduction is about 1 to 1.5. For PFM is a little more because you have a layer of metal and then a layer of porcelain. So a PFM usually is a bit higher amount of reduction, 1.5 to 2 mm. Emax also needs a little bit of thickness. Emax, relatively weaker material, highly aesthetic, so it needs a little bit of thickness, 1 to 1.5. Zirconia is a very strong material, as you know, doesn't need too much of a thickness, so about 1 to 1.5 mm of occlusal. Axial reduction for metal 0.5 to 1, PFM 1 to 1.5, Emax is also 1 to 1.5, Zirconia a little less, that is 0.5 to 1. Choice of finish line, metal finish line definitely always chamfer. PFM, you either go for chamfer or shoulder depending on which area you're giving ceramic. One more thing, one common misconception is PFM always means lingual metal and buccal ceramic, which is not always true. You can still give a completely covered ceramic on the metal coping. Okay, in that case, all over you will be doing the shoulder. Emax, rounded shoulder, and if you're going zirconia, depending on how much preparation you're doing, you can either go for a chamfer or a rounded shoulder. This is just a representation. You can use a putty index to evaluate your preparation, initially, especially in the beginning years of your dentistry, crown and bridge. You can use a putty index to evaluate your preparation. Moving on to gingival retraction. Lot of materials are available. We in MASA use Ultra Pack. Choose the correct type of cord, very important, depending on how the gingiva is, whether it is thin or thick. You can use a double cord technique also, where you place the smaller gauge cord first and then the thicker cord. This is very useful, where you can do adequate retraction. Plus, you can take out the cord the upper cord before taking the impression, while the inside the cord still remains, which gives you a better impression. Knitted cords always better, and also use a proper instrument to pack. Okay, don't use any other instrument. Always use a gingival packer. Gingival packers, both serrated and non-serrated, are available. If you are using serrated, make sure your instrument is not a very old one. Okay, because once the serrations wear off, okay, this also depends on how you or your nurse handles the instruments. Okay, once the serration wears off, then the main point of those function of that instrument is lost, because it cannot stick to the cord. Okay, and then your cord keeps coming out. So once that keeps happening with your serrated instrument, that means it is time to change your serrated instrument. Okay. Also, non-serrated instruments are available to pack the cords, where you just use a sliding action. Very important, never keep your instrument 90 degrees to the sulcus. Never thrust the cord into the sulcus. Okay, always keep it at an angle. And of course, you can use the hemostatic agents. But when you're using the hemostatic agent, again, medical history here is very important. If your patient has a cardiac problem, then please do not use any vasoconstrictors. This is just a representation of how the retraction is done. Make sure always your angulation, your instrument is at an angle and not vertical, perpendicular, pushing the retraction cord into the sulcus. So you can keep the retraction. If you're doing a putty light body, you can keep the retraction cord when you're doing the putty. You can still keep it there. But when you're doing, just before doing the light body, quickly remove the retraction cord. So you might need some assistance here, because sometimes the gingiva really bounces back to the normal position. So make sure that after loading the tray, or when your assistant is loading the tray, you remove the cord and then quickly place the impression in the mouth. So these are different hemostatic agents, and like I said, these are based on actions of based on the mode of action of this hemostatic agent. Always safe to use a biological fluid coagulant like ferric sulfate or aluminum potassium sulfate, which are not vasoconstrictors. So what are the common problems that happen in an impression? Let's just breeze through that. Inadequate margin. So you make a nice impression, you think that everything is okay, you take it out and you see that your margin is discontinuous, or there is some kind of a bubble in the margin. So what might have been the problem? Usually the problem is with the improper gingival retraction and moisture control. Okay, so you might not have done a proper isolation, you might not have done proper drying, maybe you didn't have enough time when you pull out the retraction cord and placing the impression material. So these things might have happened, and then results in inadequate margins. So make sure you do the proper gingival retraction in the recommended method, and do a proper isolation and drying. Internal bubbles are bubbles. I'll just show you the pictures. Yeah, so these are internal bubbles, which is bubbles inside, not on the margins, but it's inside the preparation, within the crown prep. So these are also usually caused due to improper handling of the material, and also moisture and air entrapping there. So make sure you have done a proper isolation and drying and efficient syringing. So when you're, in your light body, putty light body technique, when you're doing the light body part, you're putting material onto the tray first, and then you're coating the prepared tooth with using the syringe, right? So when you're doing that, make sure you completely cover the tooth surface and do the complete 360-degree movement around the tooth. Okay, don't be in a hurry. So just place the material, dump the material on the tooth. Don't do that. Okay, there is a syringe available, intraoral syringe available. So make sure the tooth is dry first, and then start going around the finish line area, and slowly start moving upwards. Okay, and make sure the tooth is covered completely and you have completely done the 360-degree around the tooth. Okay, so any areas you leave it open, you'll end up with drags and pulls. Commonly you have seen that. So once you pull out the impression, you see that there is a line going out from the tray. So that is called as a drag. So it is usually because of not syringing the light body around the tooth properly. Okay, then the other problems are when you don't place the impression tray properly. Very important basics. Like I said in the beginning, how you do your impression is very, very important. Your position, again, very important. Sometimes I see even though it has been taught in year 3, year 4, by the time students come to year 5, they kind of overlook some of the basic things. That should not happen. Basics are basics. Okay, you should stick to them. Your patient position and dentist position while doing the impressions. 11 o'clock position for the upper impression and 7 o'clock position for the lower impression. Very, very important. And also the patient chair position, very important. Please always support the head of the patient with your arm when you're doing the upper impression, and your index fingers in the canine area of the tray and your middle fingers in the molar areas of the tray. Don't use your fingertips. Always spread your fingers on the tray if it is the upper, and make sure your fingers spread from the flanges to the center of the tray. Spread the fingers properly and press in the posterior area also. Keep your chin down of your patient, not just because the material will go up, but also there are other advantages, especially doing when complete dentures. The soft palate position is very important. Okay. So select the proper tray, follow the proper technique, and select the proper impression material. Use tray adhesive, again very important. Before putting the putty on the impression tray, use the tray adhesive. Otherwise, when you're taking out the impression, sometimes it's very difficult to pull out the impression tray out of the mouth. It might lead to a separation of the tray from the impression. Some examples of bad putty impression I'm showing to you. Because of bad, so that you just know what is wrong. So you see that this area has come out quite okay, but over here it's problem. So here the problem, what has happened is the dentist has improperly seated the tray in the patient's mouth, and that's why this has happened. Now, this is another example over here, which looks, probably you might think like this is the example for a good impression, which is not. If you carefully observe over here, it might look like a proper good impression, but if you observe here, see the depth of the teeth in the tray. Okay, these areas are quite okay deep. Like I said, they should be always almost the occlusal surface of the teeth should be closer to the lower border of the tray, or the body of the tray. But over here, if you see, it's quite raised. That means the dentist who was doing this impression did not put uniform pressure all over with these fingers. Okay, so on this area there was a proper pressure applied, but over this area there was no proper pressure applied. So please don't use this putty impression. Okay, always if you see anything like this, please repeat. Don't think that the light body will cover up for this. No, the light body is not going to cover up for this. So this is the example I showed you earlier, the internal bubbles. These are the drags that you see, and these are called as the pulls. They're usually the folds of impression material you see in the margin area. This is the example of an acceptable putty impression. Okay, notice the difference between the previous pictures I showed you and over here. See the depth. Okay, see the depth everywhere. An acceptable sulcus recording, which is not very important for crown and bridge, yes, but in case of a bridge, when you have a edentulous span, then it becomes very important that the entire area is recorded properly. An example of a good impression, you see that there's a uniform recording everywhere, and a proper recording of the finish lines. Of course, today the times are changing. We are moving towards the digital. So instead of going all that hassles of impression material, using impression techniques, repeating the impression, you cannot correct the impressions, things are becoming easy now. You have the intraoral scanners, which can give you a very good digital impression, which are easily repeatable without wastage of material. They are easily correctable. That is, one certain area you cannot record properly, you can just go back and just record that area once again. Plus, nowadays, I think 3Shape Trias 4 can even help in caries diagnostics. Okay, so things are changing. One intraoral scanner can give you a lot of advantages. That is, smile designing, impression, even the caries diagnosis, plus helping in doing your diagnostic wax-ups and temporary crowns. So this is a picture of how digital impression looks like, but there are some disadvantages because it is still a growing technology. I'm sure in the future years they will overcome all these problems. One constant complaint with the digital impression is that you cannot record the subgingival margins properly, because a digital scanner, intraoral scanner, scans what it can see, or basically scans what you can see. If you cannot see your subgingival margin, then the scanner also cannot see. Okay, so make sure you have done a proper retraction, the margin is visible, and then you can scan it. There are a lot of studies done comparing the digital results of the digital and conventional impression. This is a recent study done in 2019, which shows that the amounts of internal gap and gap at the margins is much lesser in a digital impression. And the time taken for the impression again was much lesser than the time taken for a conventional impression, and the resultant crowns or the copings had very fewer adjustments to be done when the digital impression was done. Once the impression is done, the next thing is you have to do a byte registration. Byte registration for a single crown or a 3-unit bridge, you always do in MI, maximum intercuspation. No need of doing centric relation unless you're going for full mouth rehab. The most common material used is polyvalent siloxane byte registration impression material. So make sure you place it properly, make sure the patient bites properly to get a proper impression. Apart from polyvinyl siloxane, you have other materials, which is the Alminax, which is the aluminum reinforced wax. You have the modeling wax, which is usually the most economical way of doing the byte registration. Alminax also comes in wax sheets like this, and also in full arch wafers like this one. This is how the impressions look like. But generally, I would not recommend to use a modeling wax, although I am guilty of using it sometimes. But the only problem with the modeling wax is that it is not, the heating of the modeling wax is not uniform, and when you take it out from the patient's mouth also, very easily it can flex and move, and the orientation and the can change of your byte registration. Whereas the Alminax is more stable, is a bit thicker than the modeling wax. When you heat it in the boiling on hot water, the heating of the wax is very uniform. You can actually see the difference when you heat the modeling wax and the Alminax. There is a uniform heating and uniform cooling, so the errors are very less. Once you've done your impression and the byte registrations, your putty index should be ready by now. Based on your diagnostic wax up, your putty index should be ready, and use the temporary crown and bridge material. A lot of materials are available, with different pros and cons. You can, like I said, you can choose the material that you're most compatible with, and do the putty impression, and use the byte index and do the temporary crown in the patient's mouth. Make sure you're isolated properly. Make sure you have put Vaseline in all the unwanted areas, that is the adjacent teeth, the gingiva, the gums, mucosa, everywhere, because otherwise cleaning up becomes a problem. Okay, so cleaning up is much easier if you have isolated the area properly. You can even put Vaseline on the prepared teeth when you're doing the temporary crown, but make sure that once you're done that, before cementation of the temporary crown, make sure you clean off all the Vaseline from the prepared tooth. Okay, otherwise your temporary crown may not fit properly. You can use a floss. You can place the floss on the proximal surface of the abutment teeth in case of doing a bridge, because sometimes your temporary bridges will not have the proper gingival embrasure. Okay, and if this happens, and if you don't trim properly, usually when the patient comes back for a cementation appointment, the patient comes back with severe inflammation, and that is the situation when you cannot do a cementation. Okay, if your patient comes back with a severe inflammation, please do not do the cementation of the final prosthesis. Okay, you have to change the temporary crown or the temporary bridge, and make sure the mistakes that you've done last time are not there. Make sure there is an adequate pontic relief space. Make sure that the interdental areas are not impinging on the underlying tissue. So when you keep a floss like this, before you place the putty index in the patient's mouth carrying the temporary material, you're kind of assured that this gingival embrasure area is formed. Okay, so you don't have to do too much of trimming later. Also, plus it helps you. It kind of helps you for easy removal of the bridge. Okay, so next is when you take out the bridge and you start trimming. Okay, always trim. Never dry trim. I never recommend trimming anything dry without water. But always use a rubber ball in your adjacent the tray, the area which is attached to your dental chair. Use a rubber ball, and always trim using water. The next appointment, in case you're doing a PFM crown, the next appointment is metal trying. So let's just go through what are the problems that you normally face during a metal trying. This is your checklist to follow when doing your metal trying. Margins. Make sure, check for margins everywhere, proximal, buccal, and lingual. If the margin is overextended, you see many metal fins, then you can trim them. But if it is short, then there is nothing that you can do about it. All that you can do is repeat the impression. When you repeat the impression, put a light body inside the metal coping, place it on the tooth, and do a pickup impression. Okay, so this informs the technician on the area where it is short. He will pour a new cast. It will show him the area where it is short, and he can fabricate a new coping. Check for clearance, both occlusal and proximal, because it is a metal coping and the ceramic has to come over it later. So make sure there is adequate clearance as much as you need, both in the occlusal and proximal areas. Many people check occlusal, but they forget about proximal. So this is also very important to make sure about the space, because sometimes visually, if you're not able to analyze, use byte registration material on the proximal and occlusal surface. Once it is set, then you can look at the byte registration material, which gives you an idea about the thickness of the ceramic that has to come later. So any area which is thin means that area, the metal coping has to be trimmed. Check for the fit. The coping should not be either too tight or too loose. Okay. If any tight areas present inside the coping, then you can use the occlusion spray, Occlutech, you can spray inside the crown, place it inside the coping, place it on the tooth and take it out. It will show you the areas where there is a tight contact. And if you're doing a bridge and if you see that there is a rocking of the bridge, usually the culprit is overextended margins. You can check for overextended margins and trim them. If still not seating properly, if it's still rocking, probably there is some error in your tooth preparation, some error in the parallelism, especially if it's a multi-unit bridge. Then there might be some problem with the parallelism. You can check on that. Keep your burr, again, position your burr properly parallel to the long axis of the teeth and move the burr in the same position from one abutment tooth to another abutment tooth and check for parallelism. If you find any problems, modify the tooth prep and repeat the impression. If you see that there is no problems in the parallelism, everything is okay, but still your bridge is rocking, so probably your tooth preparation was good, but maybe your impression was wrong. So just repeat the impression anyways. This is Occlutech, the one that I was telling you just now, using occlusion spray to check the internal fit. They come in two nozzles over here for a spot spraying and a wider spraying. So it has different opening, one narrow opening over here and a wider opening over here. So you can spray it inside the crown area and then you can place it on the tooth and check for any internal errors. Moving over to the next appointment, that is cementation. It is more simpler nowadays. Don't have to think too much. Just go for the self-adhesive dual cure cements. Okay, makes things much simpler. Or a lot of steps are cut down. No need of doing etching bonding on the tooth, especially because the dual cure cement itself has the phosphoric acid in it, which easily etches the tooth and bonds it. So no need of separately doing etching and bonding on the tooth surface. Whereas the crown might need some treatments done to it. We'll come to that later. So what you see here are some of the resin cement, some of the etch and prime, and here is the porcelain etch and silane, which we use for the Emax crowns. Again, in the final cementation appointment also, you can use the Occlutech and all the previous things that I mentioned, some of them during the metal trying. You can use those methods to check for occlusal clearance. Not really the clearance, the contacts, occlusal contacts and proximal contacts, and also the internal fit. So this is one example where we have used the Occlutech to check for proximal tight contacts, and you see the difference over here. When the area is exposed like this, that area is the one having the tight contact, and you trim that area. Use the articulating papers for occlusal contacts. Okay, there are different thickness of articulating papers available. They range from 100 to 40 to 8 to 12 microns, depending on for what you are using. If it's for complete dentures and partial dentures, normally we use a thicker articulating paper, is about 40 to 100 microns. But if you're checking for any interferences in natural teeth, especially, you can use the 20 to 40 micron paper. Because natural teeth always have some amount of micro movement in them because of the periodontal support and all that. So you can use them for crown and bridges also to check the high points. The much thinner versions are the 8 to 12 microns, which is a shim stock film actually. These are metal foils actually. These are not colored. Usually they are not colored. And this is basically used to check for the presence of tight occlusal contacts. Okay, I can also check for proximal occlusal contacts using them. And this usually the 20 to 40 microns is the articulating paper that you use for checking the occlusal high points. Usually they are red and blue colored. There is a certain procedure to be followed when you're doing that. I will just show you this video here. If it's a double-sided articulating paper, always place the red side towards the crown. Now, you might ask why. There is no specific reason why it is. It is just a methodology procedure done so that universally people can follow the same way. Place the red side towards the crown when you're checking for the centric interferences, and you can use the blue side when you're checking for the eccentric interferences. Let's go through this video once again. So you place the red side towards the crown. Now, one very important step over here. First, you ask the patient to open and close with the articulating paper. And this step is very, very important, which most people neglect, is biting without the articulating paper. Biting without the articulating paper is very important to produce the bullseye. Okay, it's only when the opposing tooth contacts the high point, the markings made by the articulating paper, it's only when the bullseye is formed. Okay, otherwise you don't see the bullseye and you'll end up trimming all the points seen on the surface. So do not trim all the markings that are formed, because these are the normal contacts. Okay, so to distinguish between the normal contacts and the bullseye, you need to ask the patient to bite without the articulating paper. So first you do with the articulating paper, and then you do without articulating paper. Normally what we see is students, when they're checking for the high point, they place the articulating paper and ask the patient to grind. Okay, they say grind and move laterally. No, don't do that. Okay, because centric and eccentric is totally different. Always we check for centric interference first. And what is centric? Centric movement is opening and closing. You cannot check for centric interferences by asking the patient to grind. Okay, it's totally the wrong way. So always ask the patient to open and close when you check for centric interferences. Once you eliminate the centric interferences, then only check for eccentric interferences. You can use the blue side of the articulating paper, and now you can ask the patient to do the eccentric movements. Once you're done with all the trimming, you can use the porcelain adjustment kit to do the finishing and polishing. Okay, this is the Shofu porcelain adjustment kit that we use. The white stones are used for finishing, and then the rubber points are used for polishing and pre-polishing and final polishing of the crowns. For zirconia, although it's a problem, zirconia is a metal-based ceramic. You cannot use the regular diamond instruments to trim the zirconia, because there's an issue here that because the normal diamond instruments, they get chipped off very easily when they trim the zirconia. Okay, plus it can create cracks in the zirconia crown. Internal cracks. So this is not something that you want in the final appointment. So always use the zirconia adjustment kit from any brand that you like. We use the Shofu one at Masa. So it can also be used for Emax. The design of the burr is slightly different from the usual finishing and polishing burrs. Here, the diamond, it is a more densely packed diamond with the silicone binder. So you can use the discs over here to do the contouring, followed by finishing with the blue color, and then polishing with the pink color, and then super polishing with the white color burrs. Your checklist for cementation. Margins, if overextended, you can trim. If short, there is no other thing that you can do but repeat the impression just like you did for the copings during the metal trying. You put the light body, syringe the light body into the crown and do a pickup impression, and then your technician will be able to know where the margin is short. Check for contacts, both occlusal and proximal. Use the shim stock to evaluate the occlusal contacts. And the occlusion spray and the floss to evaluate the proximal contacts. And wherever you see that there is a problem, verify it with the articulating paper and trim using the recommended burrs. Fit, again, you can check using the occlusion spray to check the internal fit and then trim. Now, if in your final cementation, if you're doing a bridge, if you see that it is rocking, okay, it is an issue, especially if it's a PFM bridge. And if your metal trine went fine, but then your ceramic, finally when the ceramic has been coated and cumped for you for cementation, if it's not fitting, it's probably a laboratory error during the ceramic fabrication on the PFM crown. Okay, so there's nothing much that you can do over here. It's an unfortunate thing that happens sometimes. You just have to do a repeat impression. Okay, but if it is due to any overextended margins or any proximal contacts, tight contacts, you can just look for it using the methods that I already mentioned and trim the proximal surface or the overextended margin, and it should be fine. But if nothing works, then you have to repeat the impression. Finally, how to cement. Usually very confusing, because nowadays you have all newer crowns coming. There are so many materials available. There is so much confusion with the etching and bonding different systems and generations that we have. I have tried to summarize. If it is a metal or a PFM crown, Normally, you don't need to treat the crown. Your laboratory technician usually sandblast the inside of the crown, the metal part, of course. So there's nothing that you really need to do. Sometimes, but if your design is compromised, that is your tooth preparation design is compromised, you are over tapered somewhere, or the length or the is slightly short, then for that additional retention you might have to etch the crown. Okay, you can etch with phosphoric acid and use a metal primer, so this will give a better bonding, and meanwhile you can etch and bond the tooth surface if required only, and then you can get a better bonding. If it is your Emax, you have to treat the crown with the porcelain etch, which is a hydrofluoric acid, and then put the silicon coupling agent. So this helps in better bonding of the cement to the Emax crown. And if it is zirconia, normally just sandblasting will do. Your laboratory technician, before sending you the crown, will already sandblast. So there's nothing that you have to do in the clinic. But again, sometimes for additional retention, you can use a zirconia primer. Again, it's also based on what system of cements and bonding you're using. For the tooth as such, usually if your design is, your tooth preparation design is good, then you need not do anything. Okay. Now, normally when we prepare for crown and bridge, our preparations are already in the dentine. Okay. So there is no point in etching and bonding. Only the cervical area at the finish line, maybe you still have some enamel, so you can do a selective etching if required. Okay, but like I said, the self-curing, self-adhesive cements, they are so good. They have their own etching and bonding, so it etches and bonds the tooth directly. You don't really need to do an extra step to do that. Okay, but selective etching is still an optional thing. You can just etch the cervical area only. If you have done a post-end core and there's already a big composite core there, again, of course you need not do any treatment for the composite there. But in the cervical area, which forms the ferrule for the post-end core, you can always etch the enamel in the cervical area if it is still there. Yeah. So that's about it. So next is just a representation of how to something that I already explained to you now. If you're doing the zirconia crown cementation, when you see pictures, you understand better. The sandblasting is done. Usually the sandblasting will suffice, no need of any primer unless required. Then you remove the provisional restoration. This is very important. Once you remove the provisional restoration, make sure you clean up the tooth and the surrounding area and the gingival sulcus properly. Polish the tooth also. You can use your polishing cups or polishing brushes and pumice to polish your tooth, okay, because there are a lot of temporary cement sticking there if you don't want to interfere with the final cementation. Okay, and once you do that, normally again no need of treating the tooth with anything. Just mix the cement and then cement the zirconia crown. Because it is dual cure, yes, it can self-cure also, but it's always better to light cure. Okay, it does have some advantages. There are some advantages of light cure over self-cure. So always do the light curing. Once the moment you place the crown onto the tooth, make sure there is adequate pressure there and tack cure the composite. Okay, tack cure the composite in all the areas for 2 seconds. This will help you in easy removal of the cement. Okay, this is very important. Once you neglect that and you start curing, and then it will be a tough time for you to remove the excess cement. Okay, so always tack cure for 2 seconds all over the tooth, and then remove the excess cement, and then cure all the surfaces again for 20 seconds. Likewise for glass ceramic, like I said, if it's an Emax, then you just need to treat the crown, the inside surface of the crown with the hydrofluoric acid and silicon coupling agent. And then if required, you etch and bond the tooth. If not required, it's okay. You can directly cement and then light cure. So finally, to summarize, I'll just go through some helpful tips on the usually neglected areas. Okay. These are some things that we usually overlook. We concentrate on the bigger aspects, but these are the small things that usually can cause problems. Very important is communication. Okay, is the basic thing for everything. Communication with your patient, communication with your nurse, and communication with a lab technician. Make sure you're very clear with what you say, and make sure that the opposite person has understood also. Okay, communication is very easy now. Not like before. Now it is WhatsApp, you can email the pictures, everything. So make sure you don't compromise on that. Prior setup of all required material. Now this is very important. You might be a very busy dentist, but make sure you know who is coming next based on your appointments list, and ask your nurse to prepare everything for you. Before you start the treatment, make sure everything is there, because in between the treatment procedure, you don't want your nurse to go looking for something, or you don't want to go looking for something. Okay, so prior setup of all required materials, very, very important. Have your checklist, and then especially in your initial years of practice, you might need a checklist to follow. It is completely okay. Have your checklist, make sure everything is present, whatever you require in your vicinity. You should not be going around looking for it. A rubber dam, again, it's up to the person whether want to rubber dam or not. For crown and bridge, usually it's not a compulsion to rubber dam, but even if you're not using a rubber dam, make sure you isolate properly and keep a dry atmosphere. High volume evacuation, especially given the current pandemic situation, very, very important. Even otherwise, very important to use a high volume evacuation. Make sure along with the suction, you also use the high volume evacuation. Loops, definitely, I would recommend, but it takes a while to get used to it. If you've never used loops during your undergraduate program, then you can start going towards it. Gives you a better visualization of the tooth prep, better visualization of the surface finish of your tooth prep. Definitely helps you in getting better tooth preparations. Dentist and patient position, like I said before, also very important, especially during impression procedure. One of the main causes for failure of an impression is just the position, not just the impression material or the tray, is just where you are standing. Very, very important, where you are standing and how your patient position, how you are supporting the patient during the impression procedure is very, very important. Okay, so make sure you don't compromise on that. Even when you're doing the tooth preparation, don't be shy to ask the patient to turn the head towards you or away from you when you're accessing certain areas. Okay, you can always ask the patient politely to turn the head away or towards you. When you're doing checking for high points on long span bridges, this is something very important. Or make sure your patient is in seated position and not in a completely reclined position. Okay, especially when you're checking for high points, you don't need the patient to be in a reclined position anymore. Okay, make sure the patient is seated position, because the angulation of opening and closing always changes based on the position of our body. Okay, so we are, most of the times when we are walking around, we are in upright position and we are not in a reclined position, right? So it's very important you check for high points in this position. This is particularly important for long span bridges. Isolate and apply Vaseline around surrounding areas before cementation. I already discussed this point. Very, very important for a proper cleanup after the cementation procedure, whether it is temporary or permanent cementation. Tack curing, again, very important, makes it easier for you to remove the excess permanent cement, and floss the proximal contacts for any excess cement. Otherwise, your patient will come back with gingival inflammation. Maintenance instructions is the instructions that you give to the patient after you have done with the crown cementation and cleanup. Normally, again, this is ignored. Once the crown cementation is done, it's like everybody's in a hurry to leave. The patient is in a hurry to leave and you're in a hurry to move towards your next patient or the next thing that you're doing. So don't do that. Please take that extra 5 minutes to instruct your patient on how to maintain. Of course, you should not wait for your last appointment to say this. Okay, you're starting from the case selection, your impression, tooth preparation procedures. You need to keep on, seeding these thoughts in the patient's mind on how the patient responsibility is to maintain the crown bridges. Okay, so in dentistry, most of the treatments do not end with the last appointment. How the patient maintains them is very important. So you need to give the maintenance instructions to the patient on what to eat, how to floss, and how to brush. Final thing is limit your field of movements. Like I almost said what I said in the first and second point here just now. Make sure everything is near you, in your vicinity. Don't move around too much, especially when you have the permanent crowns in your hand. It's very scary when you move around here and there, you might drop them. Okay, so be careful. Don't move around too much. Just keep everything nearby you. If you need anything, ask your nurse to bring something and keep it near you. When you're trimming the crowns, always trim them with the on the top of a rubber ball and not on the open surface where it can drop to the ground. Okay, so that's about it. I want to conclude it by adding on about our workshop, which is going to be on 15th and 16th October, which is in the within 2 weeks now. Not much time left. What you're going to see in this workshop is about it's just an extension of what I presented today. Basically, you're going to learn on the hows and whys and how to solve the problems that you normally face, even if you are in the initial stages of crown and bridge, or if you have not done enough crown and bridge during your undergraduate, or maybe currently wherever you're working, you do not get enough crown and bridge cases, then this is the workshop that you have to come to. Okay. So apart from conventional techniques of teaching you on how to prepare teeth and conventional impressions, temporary crowns, cementation, etc., we are also giving the participants a hands-on use of the intraoral scanner. Okay, so we have an instructor coming specially for the workshop who will guide you on how to use the intraoral scanner. Especially if you think you want to move ahead with conventional impression techniques, this is something that will really help you. The price of the course is 1,800 for the general dentist, and if you are a GAP or a MASA alumni, it is 1,500. You can note down the number here. This is our student Temira. This is her number, so you can just contact her or email her here, or you can contact any of our lecturers also if you have our contacts, and you can join this workshop. Master students, the alumni, if you don't remember your student IDs, is not a problem. We still know who you are. We can still verify if required. But if you want your student ID, you can contact me for your student IDs, and I can give you your student IDs if you have forgotten it. This is some pictures from our previous workshop. Last year, we had a very successful workshop with very satisfied participants. Workshop has lectures and hands-on and demonstrations, a lot of interaction with the participants, and the participants get enough time. It's not all lectures throughout the day. It's not like that. You get enough time to prepare the teeth, do the putty index, do the temporaries, do the final impressions, and even do the cementations. So this is the feedback that we got last year from our participants. You can see that it is they have strongly agree everywhere. So it was we're quite happy to see that the students are very happy, and I hope that this year also we have a successful workshop. So thank you. I know it's a bit lengthy webinar, but then the topic is that have to cover a lot of things, and I hope it has helped you in solving your day-to-day problems when you're handling your crown and bridge patients. Thank you very much for listening to me.
Yeah. Thank you so much, Dr. Santosh, for a very informative presentation. Indeed, being a clinician, I can see there are many more informative and good tips which every clinician has to follow for a successful crown and bridge preparations, as well as the best part of the presentation was you touched right from the treatment planning till the cementation of the crowns. Thank you for giving us wonderful and useful clinical tips. And for today, we just have only one small question, which was asked by, Go Min E. Thank you, sir, for such good presentation. So could you please explain once again regarding the placement of floss during the temporization, if possible?
Okay, sure. So that is, once you have your putty index and temporary crown material ready, what you do is just place the floss adjacent to the abutment tooth. That is, if it's the anterior abutment tooth, keep it at the distal just below the distal gingival finish line, and if it's the posterior abutment tooth, keep it at the mesial finish line, and then over that you place the putty index. Okay, so of course it will need a little bit of experience to master that technique, but once you do that, it will be very helpful. So when you take out your putty index, normally you see that the temporary bridge is still sticking onto the teeth, right? Sometimes it doesn't come out with the putty index. If it comes out nice, but sometimes it doesn't come out. So in this situation, the floss you can use to pull out the bridge without breaking it. Plus, the floss will make sure that it will give you a nice gingival embrasure. I hope I've answered your question. If you're not sure, then you can contact me on WhatsApp.
Yeah, I hope Gomini got the answer for this. And once again, I would like to thank you for the wonderful presentation. I don't see any more questions here. And if any concluding remarks from your side, you can just go ahead with that.
Yeah, I hope I think probably I will take it as a compliment that there is no questions, and probably I have answered most of your questions through the webinar. So I'll take it as a compliment. And secondly, yes, what I usually tell my students when you are students or when you graduated is never stop asking questions. It's very important. Never stop asking why, which I always tell my students year 3, year 4, year 5 when they're still our students, because most of the times we talk to the student and they just listen to us. They never ask why. And even if sometimes I do this crazy thing that I just give out the wrong information purposely for that moment, and they still say okay, and then I say I just said the wrong thing to you, just to see how alert they are. So it's very important to ask questions, okay? And it's a constant learning experience. If you stop asking why, then you will stop learning also. That's how I would like to conclude my presentation today.
Yeah, thank you so much. And thank you so much for joining us. Hope you people enjoyed the presentation, and we will keep you updated with our upcoming webinars. And thank you so much for joining. Have a great Sunday evening. Thank you so much. Take care, everyone.
Have a nice day, everyone. Thank you.
Bye-bye.